Dear students, welcome to R.A.T.S in Haematology, Racing Against Time for Students in Pathology. In today's class, apart from the type of questions, you people can kindly make a note of the subjects it is involved. Medicine, pathology, pediatrics, and so on it will go on. And the first topic is beta-thalassemia. This itself can be an essay or a short note or a short essay and whatnot. Before I plunge into the topic, I would like you to kindly understand what thalassemia is meaning. The word thalas means sea and emia is a disease of the blood. It is a heterogeneous group of disorders caused by mutations that mainly affect the adult hemoglobin, which is hemoglobin A. So please understand the word mutations. We shall see what it is later on. And the main hemoglobin we are worried about is hemoglobin A, which is composed of 2 alpha chains and 2 beta chains. 2 alpha chains, 2 beta chains. The alpha chains are coded for in chromosome number 16 and the beta chains are coded for on chromosome number 11. Coming back to this, it is the most common hemoglobin abnormality. There are different types of RBC abnormalities, which can be nutritional disorders, it can be membrane disorders, it can be hemoglobin disorders, of which thalassemia is the most common hemoglobin abnormality. And nearly 4.5% of the population is affected. It can be either asymptomatic or it can manifest. In this case, there is a quantitative abnormality of hemoglobin. It is not qualitative, there is a quantitative abnormality of hemoglobin. And look at this picture over here. You people should be familiar with it. There are the alpha chains, the violet colored ones, and the beta chains, the brown ones. So there are the 2 alpha chains and the 2 beta chains, which are being connected by means of the ion to form the hemoglobin. Any reduction of one, either the beta chain or the alpha chain, will lead to a precipitation of the other. And that is the basic pathology of thalassemia. So, in this slide, we shall concentrate on the inheritance of thalassemia. Look at this particular picture. There is a red color and a green color. The red color indicates a normal gene and a green color indicates a thalassemia gene. Both the parents, they are partly affected by it. That is why I am finding half a green in both. Now, from them, we can have offspring, which can be totally normal or severely thalassemic, totally affected, or they can be carriers or traits. So this is important. Traits means they are partly affected without much manifestation of the disease. So this particular one, it is very easy for us to understand. I would like you people to draw this in the exam. As I mentioned earlier, the word thalassa means sea. So here we are finding the Mediterranean Sea and the countries in and around that region are affected by it. That is why it is sometimes called the Mediterranean anemia. Also, it is called Cooley's anemia because Thomas Cooley of USA was the person who first identified it. The importance for us is sometimes in the question paper, you can get a thalassemia or a Cooley's anemia or a Mediterranean anemia as a question, and we should not be confused. This is a better picture actually showing the world distribution of thalassemia. This green band that we are seeing shows the various countries that are being affected by it. So apart from the Mediterranean region over here, you find that even India is affected. So that is thalassemia. Also, partly there is a hemoglobin S in some regions. S means it is a sickle cell anemia. Other things we shall leave for the time being. So this will be the distribution. Mediterranean region, parts of Africa, India, and other countries. This we should have in mind. This is a very important classification which you people should by heart. So thalassemia itself, it can be a trait that is minor or intermediate or major. These are the three types as it. So what happens is, in the first case, it is a normal patient. You find that both the genes are normal. Whereas in one, I find that only one particular gene is defective, whereas the other is normal. And so also here there is a partial defect in one gene. So in all these cases, it will turn out to be a minor trait. So there will not be much manifestation of the disease. No treatment is indicated, but follow-up is required. In the next one, I find that both the genes are defective. There is a B0 and a B+, which means both are there. Therefore, it is intermediate. And in the last one, I find that a similar gene from both parents can be defective, as a result of which you get a major thalassemia, where the manifestations will be severe. So remember, there are three types, namely the minor trait, intermediate, and the major. And the rest of it, I would like you people to kindly by heart. What is this mutation, etc.? We shall see in the subsequent. Beta-thalassemia, stupid mnemonics which I had picked up from the net. T-H-A-L, TAL. So T for target cells, H for owl jolly bodies, A for anisocytosis, L for low hemoglobin and low MCV, hypochromic cells, microcytic cells. So this is one mnemonic, very easy for us to remember. And then there is another mnemonic. This also we shall memorize. Beta-thalassemia. B is capital, thalassemia is capital. So all these are the forerunners of a word. B for beta chain deficiency. T, the disease is associated with H, hemoglobinopathy. ALA, alpha chain aggregation. There are two A's over here, therefore it means aggregation. SS, splenic sequestration. E, increased erythropoiesis. So this is quite easy for you students. You are all quite sharp. You will be able to remember this. Both the mnemonics kindly memorize. This is a very important picture, a little difficult probably for us to draw, but then the pathogenesis we people can understand from this. As I mentioned in one of the first slides, there is excess of the alpha chain. Beta chain is deficient, therefore the alpha chain is more. Whenever both are present in equal numbers, they are in a soluble form. They are in a soluble form. But when one gets precipitated, for example, there is excess of alpha chain, it gets precipitated. And when it is precipitated, it is defective. Therefore, the hemoglobin is less, the cells are microcytic. That is one. But then, as it goes in the circulation through the splenic sinusoids, it is destroyed by the phagocytes lining them. Because these phagocytic cells have a tendency to pluck anything that is abnormal. Therefore, they will be removing it, leading to hemolysis. And whenever there is a hemolysis, there is a greater production of the cells in the bone marrow, which leads to widening of the diploid. That I shall again be showing you. So there is an expansion of the bone marrow. And as I mentioned earlier, it is defective, therefore there is an ineffective erythropoiesis. Also, because of the destruction, there can be an anemia. And all of this can lead to extramedullary erythropoiesis. Extramedullary erythropoiesis can lead to hepatosplenomegaly. This is one. And the patient being an anemic is subject to repeated transfusions. One. Secondly, there is also an increased absorption of iron. Both of these can lead to deposition of iron in the tissues, which is called hemochromatosis. Hemosiderosis means phagocytic cells. Hemochromatosis means parenchymal cells, such as the liver, etc. So this is the normal cell that we are seeing. You can compare. There is a severe hypochromia and there is a normal RBC. So I would like you people to kindly replay this and by heart. It is quite easy, the pathogenesis. I shall repeat it rapidly. Abnormal alpha chains getting precipitated. Therefore, there is a defect here because of the defect in the hemoglobin. Hypochromic cells, the cells are pale. The abnormal hemoglobins are sequestered and the cells are destroyed. Based on the destruction, there is increased amount of production, increased erythropoiesis. Because of ineffective erythropoiesis, there can be an anemia, and this will lead to again extramedullary hematopoiesis or erythropoiesis. Repeated blood transfusions are required. More iron is absorbed. The patient can land up with hemochromatosis. This is the development that we had mentioned earlier. So this is a carrier over here, another carrier over here. When both of them get married, you find that there can be an unaffected child or a child that is totally affected. And there can be two which can be carriers of the disease. What is the basic pathogenesis? I had shown you in the flow diagram earlier. It is here. There is increased phagocytosis. When both alpha and beta are present in the same quantity, they are soluble. There is no precipitation. Absence of any one. Alpha is absent. You find that there is alpha in the beta will lead to precipitation of the alpha chains. Therefore, there is phagocytosis and destruction of the RBCs. You can read it like this. Reduced synthesis of the beta chains, hyperactivity of the spleen can lead to anemia. And this is the shortest form, please by heart. Intramedullary red cell destruction, ineffective erythropoiesis, shortening of the red cell lifespan, and increase in the plasma volume. All can lead to anemia. This is usually not an undergraduate question, but we shall know. This is called the molecular basis of thalassemia. You find that this is a particular chromosome, and in this there are various points which can be subject to mutations. And these arrows are all pointing out to various particular points where a mutation can occur. Because of this mutation, there can be abnormality in the hemoglobin production. There are usually a promoter and a codon region, 3' and 5'. And there can be these types of mutations. Kindly by heart this alone. This will be more than enough for you. There can be a splicing point, a promoter, or a stop codon. 3 types of mutations can occur, leading to there can be a defect in the transcription, defect in the RNA splicing, and defect in translation. Defect in transcription, defect in RNA splicing, defect in translation. So what will happen whenever these are abnormal? Normally you find that they are all removed by means of a process called splicing. They are all removed and you have a absolutely normal chromosome. Whereas in this particular case, these persist and they are subject to mutations, because of which different types of thalassemia can occur. B0, B+, etc. And This diagram is again given in your Robbins. I would like you people to go back to it. Blood picture. This is definitely mandatory in hematology. The hemoglobin is moderately or severely decreased. So there is an anemia. What is the type of anemia? You find, so this is a hemoglobin 3 to 9 grams. PCV is also correspondingly decreased. The RBCs are microcytic. So these are all cells which are small, microcytic, hypochromic. You look at the pallor of the cells. You find that the cells are pale. This is a hypochromic cell that I'm seeing. There is a thin rim of hemoglobinization that is seen. A lot of cells have got a central area of hemoglobinization also, and they are called as target cells, just like a bullseye or a target in a rifle shooting. That is why the name. And there can be some fragmented cells. Schistocytes are over here. Hypochromic cells, target cells, anisocytosis, etc. And this is almost similar to your iron deficiency anemia. Only thing is, because of hemolysis, there can be increased production of nucleated RBCs, which is not common in iron deficiency anemia unless there is a treatment. There can be a basophilic stippling. So remnants of the RNA can be seen as stippling dots. Teardrop cells can be present. Howell-Jolly bodies. These are all remnants of the RNA that can be seen. So this particular one kindly memorize. You can write it in a paragraph form or point form. RBCs are microcytic hypochromic with moderate amount of anisopoikilocytosis. A good number of teardrop cells, target cells can be seen. A few cells show basophilic stippling. Polychromatic cells and nucleated RBCs can also be seen. Howell-Jolly bodies are present in some. So almost the same thing. In this one, I'm able to see a teardrop cell. Numerous target cells are seen, which are otherwise called as podocytes. This is called a Mexican hat appearance. A Mexican hat, from the top, it will be appearing like this. So it is called a Mexican hat appearance. Being a hemolytic anemia, the reticulocyte count is increased. Normal is 0.2 to 2%. In children, it can be up to 4 or 5%, but here it is 5 to 10%. The erythropoiesis is ineffective. Methyl violet will be showing alpha chain precipitation. Punctate basophilia can be seen. And leukocytes are normal or slightly increased, platelets are normal. It is basically a disease of the hemoglobin. And the patient can be having a mongoloid phases. We shall see what it is. There can be a crew cut appearance. This also we shall be seeing. The bone marrow is not mandatory for the diagnosis of any hemolytic anemia. Please remember this, it is not mandatory. But for the sake of completion, we are mentioning. It is hypercellular, erythropoiesis is micronormoblastic, and then there can be numerous ring sideroblasts. Leukopoiesis is normal. Lymphocytes, plasma cells are all normal. Iron stores are increased. In iron deficiency anemia, it is decreased. ME ratio, it can be reduced or reversed because more of erythroid production is there. Normally, myeloid is more, but here erythroid is more. Therefore, the ratio can become reversed. So, what are the features of it? This you people can mention. So, there is a failure to thrive. So, there is a lagging behind on the landmarks. Skeletal changes can be there. Widening of the deep lobe. And here you find that there is a frontal and an occipital bossing that can be present. Hair on end appearance. I'll show you the picture. Mongoloid faces. Hepatosplenomegaly. Jaundice. Any form of hemolytic anemia, jaundice should be there. Delay in puberty, anemia, severe infection, sometimes death can be there. And what will be the further manifestations? Recurrent hemolysis, repeated blood transfusions. Because of that, there will be iron absorption and deposition. Hemochromatosis will be there. Apart from that, there can be cirrhosis and all these changes. Some patients, whenever there is a hemochromatosis, islet cells can be destroyed, there can be a diabetes. So this is definitely mandatory for us to by heart. Look at this picture. It is showing a massive splenomegaly and a hepatomegaly. So look at this region over here. This is the mongoloid faces. The malar bones are prominent. You find there is a lifting up of the nose. There will be slightly slanting eyes and protrusion of the teeth. A mongoloid faces is classical. And this is a radiological picture. This is a inner and the outer diplo. I find that there is a widening because there is increased amount of bone marrow cellularity. And there can be a reactive bone that will produce a hair-like appearance. This is called hair on end appearance. Hair on end appearance, we used to give it as an MCQ. Mongoloid faces as an MCQ. Chipmunk faces as an MCQ. And look at autopsy. You find it the skull, obviously it has been removed. And I find that there is a widening of the diplo because of the increase in the marrow. There is the inner and the outer and the inner diplo. There is a widening of the marrow space, and this is seen over here, but still it is spongy. And a beautiful hair on end appearance that you people can see in thalassemia or any form of hemolytic anemia. This is a little different. We call it a sickle cell thalassemia. All of us know the hypochromic cells as well as the target cells. But here I'm finding other cells called the sickle cells. So both can be seen in combination, common in areas like Pakistan. Go back to the geographic map, you will be able to see where it is. There can be microcytes, target cells, polychromatic cells. Spherocytes also can be seen. These are all spherocytes and sickle cells. What can be the investigations? So this is one. Whenever you people are asked the investigations, you must write non-specific investigation, specific investigation. Non-specific. For example, hemoglobin, serum bilirubin, red cell indices. These are all non-specific. And specific means it has to be specific for the disease. For example, here it is an electrophoretic machine, and I will have to separate the abnormal hemoglobins. So this will be specific in diagnosis. So I always used to tell the students, in fact, I have mentioned this in an earlier class also, there are two forms of electrophoresis, agar gel electrophoresis and cellulose acetate electrophoresis. And these will be helping to separate. These are all different types of hemoglobins, and because of the movement between the cathode and the anode, you find that they will be separated. This is called hemoglobin electrophoresis. Now, why am I showing a train in the background? Look at this one, A2. You can say that B2 are getting into a train. And then we say see you to our friends. A2, that is B2, are getting into a train. We say see you to our friends, CEO. And the train starts moving. It has got a rhythmic movement. SDG, 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 SDG. So S, D, and G get separated. We go to the fag end of our journey, get down at a station called B.A.T.S and go home. So this is one easy mnemonic by which we can remember the different hemoglobins and electrophoresis. A2, CU, SDG, fag end of the journey, B.A.T.S and going home, hemoglobin H. There is another test called the Nestrov test. Nestrov is naked eye, single tube, osmotic fragility test. This is a normal control. I'm having a printed material behind. I'm able to read the print because there is no hemolysis or precipitate. Whereas in the test, there is a precipitation. I am not able to see the print. So this is called as Nestrov test. You people can mention. And look at this one, the chipmunk faces, malar prominences, mongoloid faces, prominence of the tooth, frontal bossing can be there, more prominent, occipital bossing can be there. There can be a crooked appearance on an X-ray. Failure to thrive, other things you people can add. What can be the treatment for it? Repeated blood transfusion will be mandatory. Chelation, because of iron, you have to remove the iron. That is chelation. Splenectomy, when the child is more than 6 years. Treatment of the complications. The child can go in for cardiac failure. Supportive treatment is required. Ultimately, a bone marrow transplantation may be the need of the hour. So this will be the treatment. And what is the prognosis? The life expectancy is short, 15 to 25 years. The child dies due to severe anemia and cardiac failure. Recurrent infections, hemochromatosis can produce cirrhosis, diabetes, and cardiac failure is the thing. I hope you people have enjoyed the class. You will be able to recollect and reproduce everything in beta thalassemia. A very important essay question. Thank you.